Hello, my name is Brian Lawless, and I'm the Medical Director at the Elliot Hospital Center for Orthopedic Excellence. I'm also one of the hip and knee surgeons who operates here routinely. Having an understanding of what this process entails, from the preoperative preparation to the procedure itself and to everything that follows in the recovery period, can help decrease your concerns, make the process go more smoothly, and ultimately lead to a wonderful outcome. Whether it be me or any of your other talented surgeons, your nurses, your physical therapists, and your case managers, we all believe strongly that providing accurate patient expectations can improve your overall experience. What's to follow is meant to be an outline of what your experience will be. If you have any specific questions, please don't hesitate to reach out to your surgeon's office and have those addressed promptly. Hopefully, you're looking forward to your hip replacement and getting on the road to recovery that will lead to improving your quality of life. A hip replacement can be a big undertaking and sometimes comes along with some anxiety. This is completely normal. Thank you also for watching this video. Our team has put a lot of thought and effort into providing a detailed educational experience for you prior to your surgery. We hope you find this information useful, and we look forward to seeing you at the Elliot.
Hi, my name is Sally. I'm a nurse case manager. My job is to work with you post-operatively and help come up with a discharge plan from the hospital for you. So we meet either the first day post-operatively or the following morning. We talk to the therapy department, we talk with you, we talk with whoever you have identified as a caregiver or a support in your home and come up with an appropriate plan. What we encourage is that you review your list of home care agencies prior to your surgery and choose who you'd like for a home care agency. If you have any questions at all about home care and what that entails, that physical therapy coming out to the house, potentially a nurse coming out to the house to check in on you, you can call our department here, Care Coordination. Preoperatively, there are things you want to ask yourself. Who's going to be staying with you when you go home? Who is your support person? Who is your caregiver? You want to prepare that person and make sure that they can be with you at least for the first week that you're home. You want to have meals prepared in advance. You want to plan your transportation home from the hospital. And to any appointments you may need to go to. Therapy will talk further about preparing your home setting for when you first come home, staying on the first floor, any equipment you may need. In very rare circumstances, sometimes people go to a skilled nursing facility post-operatively, depending on what their needs are. Because this is an outpatient procedure, depending on your insurance, you may have to pay room and board at a rehab facility, so that is something for you to be thinking about prior to your surgery. And that is something that the case manager can certainly talk with you as well. In terms of, I'll go back to your hospital stay and how long you'll be here, that will be something I encourage you to speak with your surgeon about prior to your surgery, how long they think you'll be in the hospital. But again, it tends to be either a same day or the following day heading home with home care. In the rare circumstance that you do need a facility following your surgery, you have a list in your packet. Please review that list. Think about 3 facilities that you would prefer to go to. We would try our hardest to get you a bed at the facility that you choose. However, depending on insurance limitations and bed availability, we may not be able to get you to your first choice, but we will work with you on that. Of note, we like to have our files complete. If you have an advanced care directive or a durable power of attorney for healthcare document, please bring that with you and we'll make a copy of that and put that in your record for you. So we'll have that for future. When you bring it in, you can actually either give that to your nurse or to the case manager, and we'll get that into your record. Hopefully, when we come to see you, you'll be in your chair and not in your bed. And we look forward to seeing you, and good luck with your surgery.
Hi there, my name is Kelly, and I'm one of the resource nurses from the Fuller Unit, Total Joint, and Post-Surgical Care Unit. I'm here to talk to you about what you can expect with your upcoming knee, hip, shoulder, and spine surgeries while you're here in the hospital. We have several orthopedic and spine surgeons that are all great, but they all do things a little differently. So this is a general overview of what you may experience. You and your surgeon will discuss things in more detail at your pre-op visits. To start, we encourage you to begin by preparing at home for your upcoming surgery. It is important that you remove all scatter rugs or long cords from your house that may be easy to trip over. You will be going home with a walker, cane, or crutches and those rugs and cords can be high fall risks. I also like to encourage people to make meals ahead of time, especially if you live alone. Or even if you don't, it will make things easier for you and one less thing you have to worry about. You also want to think about where you will be staying once you go home, especially if you do live alone. If you are alone, you should try and plan ahead and have someone stay with you for the first couple of nights you are there. Try and set up where you will be in your home, whether it's on the first floor or upstairs. If you do have stairs, our therapy department will be working with you on this prior to your discharge. Please make sure you bring an updated medication list with you to your pre-op visit with your surgeon, as well to the hospital on the day of surgery. This list should include the name of the medication, the dose, and the frequency in which you take it. Make sure you also include the meds you take as needed. Do not bring in your actual meds unless we ask you to do so. I also tell patients that they are more than welcome to bring in their own toiletries. If you choose not to, we do carry the basics. We encourage you to bring loose-fitting clothing like shorts, sweatpants, or nightgowns. Comfortable clothing that you can easily wear after surgery. Your nurse, surgeon, physician assistant, or nurse practitioner will all want to look at the surgical dressing to make sure it is okay. So wearing that loose-fitting clothing makes it easier for us to assess this. We would like you also to bring a pair of sneakers or a sturdy pair of shoes with a back to them, but please no flip-flops. If you also have sleep apnea and use a CPAP machine, please bring it in with you the day of surgery and make sure it is labeled with your name. If you also own a walker, crutches, or a cane, feel free to bring it in with your name on it as well. All of our patients use a walker at first, and then the therapy team will assess you after surgery and decide which device is best for you. If you do not own any of these devices, then we can help you with that, but also feel free to reach out to other family members and friends that may let you borrow them if they have these available. You will be receiving a call from the surgical daycare nurse the night before surgery, and they will review with you what meds to take and what meds to hold. They will also let you know when to stop eating and drinking. On the day of surgery, you will enter through the main entrance and check in at the main desk. Let them know that you're here for surgery and they will direct you to the surgical daycare unit. There, you will be greeted by your nurse and the rest of the healthcare team. Here they will prep and prepare you for surgery. You will find throughout your stay we may repeat many of our questions. This is a precautionary thing so that we make sure that we're all on the same page. When it is time, they will wheel you over to the operating room. Once your surgery is done, you will recover in the PACU, which stands for Post-Anesthesia Care Unit. Here, you will slowly start waking up from surgery. They will monitor you for at least an hour as everybody wakes up differently from anesthesia. You may wake up with oxygen in your nose, IV fluid running, a catheter in your bladder, and sequential compression stockings on your lower legs which help prevent blood clots. When you are stable and awake, they will then transfer you to either the Fuller unit or the Total Joint and Post-Surgical Care unit. Upon arrival to one of these units, you will be settled into your room and we will orient you to the staff and the environment. You will be hooked up to a vital sign machine, which will stay on for up to an hour so that we can monitor your blood pressure, heart rate, respirations, and temperature. In some surgeries, a spinal and blocks will be used and your surgical limbs may still be numb or weak. We will keep you in bed until it's safe to try to get you up. Our goal is to have everyone up out of bed the day of surgery. During your hospital stay, we ask that you please ring for help at all times. Everyone will have a bed and chair alarm in place for safety so that you don't fall. The staff will frequently be checking on you and checking your extremities and doing CSMs, which stands for circulation, sensation, and movement, along with your pulses in your feet and wrists. The staff will also be asking you if you have any numbness, tingling, or pain in your extremities. This helps us monitor for when your spinals and blocks are starting to wear off, as well as making sure you have good circulation. Some of the other equipment you will see on the units includes this Volt phone. First of all, you will see the staff using these phones, and they are for hospital use only. We use them to communicate with the rest of the healthcare team, so they are not our personal phones. You will also see a pole and an IV pump, and you may also get a couple antibiotics after surgery to help prevent infection. We also have, for ice, this cryo cuff, which is a fancy ice pack for our knee patients. And if you're having a hip or a spine surgery, we will give you some of these ice packs. The incentive spirometer is for every patient, and it's going to be educated to you after surgery, and this helps prevent pneumonia. These are TED stockings. They help with swelling and blood clots. Not all doctors order this. You will be given a second pair to go home with if they do order them. Sequential stockings. These help also to prevent blood clots, and everyone will have these after surgery, and you will wear them at all times while you're in the bed. If you are having a shoulder surgery, then you will have some type of sling on your arm. Drains, which may sometimes be present but isn't determined until your surgery. Your surgeon makes that decision when in the OR. If you do have one post-op, then they are usually removed within 24 to 48 hours. It will depend on the amount of drainage that occurs. Back braces may also be ordered depending on your spine surgery. Usually, you are given your back brace prior to admission. Please make sure you bring this brace to the hospital if you are asked to wear it post-op. If you are having a cervical spine surgery, then you may have a hard or soft cervical collar. These are to stay in place at all times unless the staff is assessing your surgical site or unless told otherwise. There are also gait belts and walkers in every room. We will be using these to assist you up out of bed, up out of the chair, and to walk you in the halls for safety and to prevent falls. Foley catheters. If you have one of these, it's a catheter that is inserted into your bladder and will be removed as soon as you get your full sensation back into your legs and that you are able to bear weight without your legs buckling. As far as dressings go, each surgeon has their own dressing that they like to use. Some examples may be a dry sterile dressing, sometimes covered with a big ACE wrap and sometimes just covered with tape, or some type of silver dressing over the incision. Certain ones called a Mepilex AG and the other one is called Silverlong. These also sometimes are covered with ACE wrap. All of these dressings are changed at different times depending on your surgeon's preference. Upon discharge, you will be instructed on when the dressing is to be changed or removed. After surgery, you will be hungry and your surgeon will have ordered you a diet. Our staff will assist you with the menu and show you how to order your meals. Our goal after your surgery is to make sure your pain is manageable and tolerable, but not always pain-free. After surgery, we will transition you over to oral pain medication that your surgeon will have ordered. These are usually the same pain medications that you will be going home with. If you are having a lot of pain, then we will use the IV medication as last resort. Please make sure to let the staff know if your pain is not being controlled so that we can address it. Pain medications can also make you sleepy, weak, and sometimes dizzy and lightheaded. This is another reason we want you to ring for help and not get up alone. Pain meds can also cause constipation, so you will most likely be on some type of stool softener after surgery. We also recommend you buy some for home for when you are discharged. Like I mentioned earlier, our goal is to get you up out of bed and walking the day of surgery, and we will continue to do this throughout your hospital stay. We will also let you know if you have any weight-bearing restrictions. If your surgery is earlier in the morning, then you will be seen by a therapist later in the afternoon. If your surgery is completed later in the day, then you will be seen by the therapist the next morning. If your surgeon feels you don't need to be seen by therapy, then the nursing staff will assist you. Our staff works very closely with our therapy team. If you have a spine surgery, then we will also be reviewing the No BLT, which stands for no bending, lifting, or twisting. You will also get educated on how to log roll in and out of bed as part of your spine precautions. If you are having a knee and hip replacement, you will also be on a blood thinner. Most surgeons are using aspirin, but if you are on a blood thinner prior to surgery, they will resume your baseline medication. This helps prevent blood clots. Blood transfusions may also occur in some cases. There is a blood bank right here in the hospital. Most surgeons use this as a last resort, and only if you are symptomatic. This doesn't happen often, but we want to make you aware of it in case it is needed. At the change of shift, you will also notice the off-going nurse and your new nurse coming into your room to give report at your bedside. We call this bedside reporting, and it allows you to be involved with your care during your hospital stay. This is also a non-smoking hospital, so no smoking is allowed anywhere on the hospital grounds, and it can also interfere with your healing. Showering is allowed, but you cannot get your incision wet or the original dressing wet. Bacteria likes moisture, and it can increase your risk of infection. We tell patients to buy Press and Seal for home, and before showering, wrap the dressing with the Press and Seal. This can help prevent it from getting wet. Pain medication prescriptions will be given to you by your surgeon. Some surgeons give you a prescription prior to surgery so that you already have them filled and waiting for you at home. Others will give you prescriptions the day you are discharged. If you are given prescriptions the day you are discharged, then we do offer an optional program called Meds to Beds. It is offered Monday through Friday. A pharmacy tech will take your prescriptions and get them filled for you and bring them right back to your room before you go home. Prior to discharge, your nurse will review all of your discharge instructions and medications with you so that you are prepared for home. We really hope you enjoy your hospital experience, and we really look forward to meeting you.
Hi, I'm Hannah. I'm a physical therapist here at the Elliot.
And I'm Laura. I'm an occupational therapist here at the Elliot. We may be one of the therapists who will be assisting you during your stay here. Our role as occupational therapists here at the Elliot is to make sure that you can take care of yourself after your surgery, but also to determine any support or equipment you may need to discharge safely.
Our role with physical therapy is to teach you about your weight bearing and movement precautions after your hip surgery set by your surgeon. And we will also be assessing how you're moving, your range of motion, your strength in order to determine what you need to be able to do to discharge safely. Depending on the time of your surgery, our goal from physical therapy is to see you the day you've had surgery. The evaluation begins with questions about your home environment, including stairs to enter and whether or not you have railings, and stairs within your home, because you may want to consider setting up sleeping arrangements on your first level. We'll also be asking about equipment you have available to you, your bathroom setup, and supports you have to help you. If we're unable to see you from physical therapy that first night, your nurse will help you up out of bed, and then both occupational and physical therapy will see you the next morning.
In preparation for your hip replacement, you can best prepare by removing clutter and throw rugs in your home, widening pathways for potential walker use, or determining who will be your support system for you and your pets. If you live alone or are the primary homemaker, it would be beneficial for you to prepare meals in advance, lay out clothing, or place important items in easy-to-reach areas.
As we progress towards discharge, we'll be discussing with you the equipment we'll be recommending for you and how to best obtain this equipment.
First, we will start by assessing how you do getting out of bed. If you find that you have trouble with this after your hip replacement, we will show you how to use a leg lifter. First, you place it over your foot and then use your arms to bring your leg in and out of bed. We will go over how to get dressed in occupational therapy. If you are having trouble bending forward after your hip replacement, or you have surgical precautions limiting how far you can bend forward, we will show you how to use adaptive equipment such as a reacher and a sock aid. This is a reacher. You can use it to take off your socks and to put on pants and underwear. It is usually easier for you to dress your surgical leg first when putting on pants and underwear. This is a sock aid. You can use it to help you put your socks on without having to bend forward down to your feet. First, you put the sock on the sock aid, making sure that it is nice and tight up at the top. Then, use the handles to bring the sock aid down to your feet, place your foot in, and pull. An important consideration is to make sure that the height of the surfaces you are sitting on are not too low, including the toilet. This is especially important if you have surgical precautions after your hip replacement. You may obtain a bedside commode or a toilet riser to help make sure that your toilet is at the appropriate height. When getting on and off the toilet, always reach back for the surface or use a grab bar. Never hold on to the walker. When getting in and out of the shower, it is always best to step into the shower using your non-surgical leg. When coming out of the shower, it's the reverse. Make sure to lead with your surgical leg. This is one way that you can get in and out of the shower after your hip replacement. Your occupational therapist may determine that you would benefit from a shower seat or a tub transfer bench, depending on your type of shower or surgical precautions. We will go over this with you while you're here.
We will assess the range of motion and strength you have available in your arms and legs. Are you able to lift your arms up? Good. And then march your knee up. Good. And then kick. Awesome. When we help you get up and moving during your stay, we always use this piece of equipment called the gait belt. It goes around your middle so that we have something to hold on to in order to keep you safe. When it comes to standing from a sitting surface, most of our patients will have weight bearing as tolerated orders set by their surgeons, which means you'll be able to put as much weight as you feel you're able to when you make that transition. To start off, you're going to push your hands from your sitting surface, and then they will transition to the walker. To ensure that you have the proper fit of your walker, we can look at the wrist compared to the grip. If they're aligned, you're good to go. Once you're standing, we'll teach you how to begin to walk. You'll start by pushing the walker, stepping your surgical leg forward, then your non-surgical leg to it. As you build your strength and confidence with this, we'll begin to teach you how to progress to a more natural walking pattern. During your stay, we'll instruct you on how to safely navigate the stairs with the use of a railing and/or an assistive device. When going up the stairs, you begin with your non-surgical leg, and then you meet your surgical leg to it. And then you repeat that all the way up in order to safely get into your home. To come down, you lead with your surgical leg, and you bring your non-surgical leg to it. One step at a time, up with the good, down with the bad. At the end of your assessment, we will discuss with you pain management, including use of ice, the benefit of activity in reducing your risk of blood clot, and we'll also be going over a home exercise program with you. This home exercise program will be available to you on the Elliot website. During your stay, and depending on your progression, we'll make recommendations on the appropriate equipment for you to use, like a walker.
Also, when getting in and out of the car, always be sure to sit down first, facing out, before you swing each leg in to face forward. As we work with you during your stay here, we will determine if you would benefit from continued therapy upon discharge home or at a short-term rehab facility. We may even ask for a caregiver or family member to come in for a therapy session, depending on your needs and progress.
Thank you so much for taking the time to watch this video.
We hope you found this helpful, and we look forward to working with you during your stay here at the Elliot.
Hi, my name is Dave Arndt. I'm one of the anesthesiologists at the Elliot Hospital in lovely sunny Manchester, New Hampshire. I'm here talking to you today to go through some of the processes behind the anesthesia for various orthopedic procedures. Typically, you come in, you meet your whole team for the day, your anesthesiologist comes and speaks to you, goes through your history with you. You'll meet a nurse anesthetist as well. We do use a care team model here at the Elliot Hospital. That means that an anesthesiologist works with one or more nurse anesthetists, up to as many as 4 at a time, and it's a great model. When I came out of training many years ago, I never thought I was going to be working with other people in that fashion, but I've actually really enjoyed it. It's a great way for a couple professional sets of eyes and hands to be involved in every patient's care. It also allows me to see a lot more patients through the course of a day, and so I get to see total hip arthroplasty. We're getting into the part here where I'm going to be talking about obviously lower extremity joint replacement, so hip replacement, knee replacement, and I want to say up front that you may have heard things out in the community, you may have friends who've had these procedures done. I learned really early on going to the class that all anybody wanted to hear me say was, you're going to be asleep during your surgery. And I'll say that now, you're going to be asleep during your surgery, whether it's the total hip, the total knee, the total shoulder, or the spine procedure. So whatever you've heard, put it out of your mind. That's not to say that for total hips and total knees, that's your primary anesthetic, because it's not. Typically and traditionally, we've used spinal anesthesia for both of those procedures. In recent years, both of the lower extremity replacements, hips and knees, have improved a lot for the patient experience, and they've improved for different reasons. In the case of the hip surgery, the hip replacement, the actual surgery itself has improved quite a lot. Most of the time today we're using an anterior approach to the hip replacement, which doesn't involve cutting muscle, whereas previously we did a lateral or posterior approach to hip replacement surgery. Now some people are still going to have that lateral approach or posterior approach, and it does make for a slightly more difficult recovery, but for the people having the anterior approach to the hip, they're going to do quite well after surgery, and typically people feel quite good. We traditionally haven't really done any nerve blocks for the hip replacement surgery. We do a spinal anesthetic. The reason we do spinal anesthesia for lower extremity joint replacements, there are actually many reasons why we do, but I think the biggest reason is anytime you can block signals from a surgical site to the brain, It's a good thing. You know, your brain is composed of sort of a primitive part of your brain, which is responsible for keeping you alive in the wild, and you have no control over that part of your brain. And then there's also your conscious brain, which of course you make decisions and you're aware of things around you. Now, we can, in the anesthesia world, make you unaware of things around you. We can make your conscious brain feel relaxed and not care about things around you, but the primitive part of your brain is a lot tougher nut to crack, if you will. When we put people to sleep with general anesthesia, even though you're unconscious and you're unaware of what's happening around you, the primitive part of your brain is still receiving pain signals from the surgical site, and total joint replacements for your brain feel like a very significant trauma. And your body, your brain, reacts to trauma in a very primitive way. It wants you to survive that experience. Well, we know you're going to survive this experience. We're getting you through it. We're going to put everything back as a neat package when everything's done. We don't need your primitive brain to do that for us. And your primitive brain, when it detects a trauma, surgery, it goes into this survival mode. It wants to protect the brain, it wants to protect the vital organs, it shunts blood from the periphery to the core preferentially, it makes your blood thicker so you clot more. These are maladaptive things in the surgical world. We don't want those things to happen. It also makes you want to go crawl in a corner and rest. We don't want you to rest after this. We want you to use your new joints, because that's what's going to give you a great outcome down the road. So it's going to be very important that we do everything we can to block that part of your brain's response to the surgical process. Now, even your conscious brain can make some of those things happen. We're all familiar with the fight or flight response. You know, you get anxious, your mouth gets dry, like mine is a little bit right now talking to this silly camera, and you can feel your pulse go up. You know, so even your conscious brain can trigger some of those responses, but not quite to the degree that the primitive part of your brain can. So that's where the conscious part of the medication comes in. You know, that's why we use sedation. That's why we want you to feel comfortable and relaxed when you come in to meet us. And so when we do hip arthroplasty, we use spinal anesthesia as the primary anesthetic. Unlike general anesthesia, spinal anesthesia, which makes you numb from the belly button down, completely blocks the signals from the surgical site at the time that the trauma is happening. Now, your brain eventually, of course, is going to figure out that something's happened when that spinal wears off. However, by that point, everything's back together in a neat package, the tissues are touching. Your brain, we have pain medicine on board, your brain catches on that something happened, but it doesn't seem as traumatic to your brain. And so it's a good way to get you sort of through that primitive brain response. And again, it's going to happen to some degree, but we at least can blunt it and get you up and moving early, hopefully avoiding blood clots and those other complications that we can see after traumatic events like a surgical procedure. In the operating room, after you've had, so you come in for you come in for your hip replacement surgery, you meet your fantastic team. You're going to meet your nurse in the block room, who is going to be wonderful, as they all are. You're going to meet your anesthesiologist, your nurse anesthetist. You'll meet also the circulator from the room. All these people are going to come and talk to you before you go off to surgery. You're going to be probably feeling quite anxious. We expect this. This is normal. And again, we're going to want to knock that down a little bit before we do anything to you, because it's going to help you have a better outcome later. So before we place the spinal, you get very nice relaxing medicine, should have you feeling cool, calm, and collected. We also talk a pretty good game in the moment, and hopefully can talk you off the ledge too if you're not feeling well. To place the spinal, we have you sit up. We actually have positioners that will help you get into the position. It's basically a position of very poor posture, where you're kind of slumped over and your chin's on your chest. You're going to be pushing your low back out towards your anesthesia provider. We're going to clean your back with some cold soap. Use a very small needle to put some local anesthesia in and just under the skin. That's going to pinch and burn for 5 seconds. It's not terrible. And then after that, it should feel like somebody's pushing with their finger. We'll get into the subarachnoid space, where we put spinal medicine, give you your spinal dose, and then head off to the operating room. And in the operating room, you're going to be fully monitored. You'll be breathing oxygen, breathing on your own. We're going to infuse one medicine through the entire case that's going to keep you just under that line I was talking about earlier between consciousness and unconsciousness, because in this case, there's going to be absolutely no surgical stimulus from below your waist. So it's really just the medicine's only fighting the sights and sounds of the operating room, and keeping you in a nice light nap. At the end of the procedure, we'll shut that medicine off. You'll go to recovery. You should wake up very quickly, hopefully feel good very quickly, and initially be very comfortable, because your spinal will still be in effect. As that spinal wears off in the recovery room, your nurse is going to work pain medicine in, hopefully keep you on a nice even keel, and when you look like a peach, which you will, or a rose, or whatever you want, we'll kick you out of the recovery room and you'll start the hard work of using your new hip. Now, a lot of people at this point, when I'm doing the live class, will raise their hand and say, hey, I've had 12 levels in my back fused. I've got hardware everywhere. I've got a plate, this thick and here and there. And does that mean I can't or shouldn't have a spinal? And the answer is not extremely straightforward. We always like to try. Most of the time we can get that spinal in and we keep you comfortable again and relaxed through the whole thing. We don't always get the spinal in. So sometimes, not commonly, but occasionally we do have to put somebody to sleep to get them through their hip replacement. Same is true for knee replacement surgery as well. The added complicating factor here is that most of the people who are here having their joints replaced are experienced, wise, but they've also had a lot of time for their spines to collapse. We all lose a little height over time, and so the target that we're shooting for with that spinal needle gets smaller and smaller and smaller. So occasionally we're not able to do it, but most of the time we are, and it's great anesthetic, and again, going to keep you safe, hopefully give you a fantastic anesthetic experience so that when you walk out the door you say, man, those people were incredible. Thanks a lot for your time. I didn't get to see you today, but hopefully I'll see some of you day of surgery, and look forward to seeing you.